Good morning, everybody, and welcome to Pediatric Grand Rounds on WebEx. I'm Suzanne Mazer, and I'm the Director of Continuing Medical Education here at Seattle Children's Hospital. Just a couple of announcements from me. Mandatory reminder, please remember to mute your audio to avoid any embarrassing gaffes. So please mute your audio at the beginning. If you have a question for our speaker, I'll ask you to type it in the chat feature, the chat with everyone feature. I will ask your question to our speaker at the end of the presentation. If you want to, you can then unmute yourself if you want to clarify your question or ask a follow-up question. And you will be sent an evaluation by email during the week after this presentation. So please look for that in your email and please fill it out for us. And now I'll turn the virtual microphone over to Dr. Shaquita Bell, who's going to introduce our speaker for today. Thanks, everybody, for being here.
Thanks. I'm super excited for this grand rounds. Molly Fuentes is an assistant professor in physical medicine and rehabilitation and pediatric rehabilitation medicine. She went to medical school at the University of Michigan and did her residency at the University of Washington in physical medicine and rehabilitation. Her fellowship was in pediatric rehabilitation medicine, also at Seattle Children's and the University of Washington. I'm super excited because her interest lies in traumatic brain injury and health disparities in American Indian and Alaska Native children. And on a less official level, I consider Molly a good friend of mine and feel really lucky to be able to hang out with her occasionally. She is a member of Warm Springs Confederate Tribe in Oregon and is a real excellent researcher in the field of American Indian, Alaska Native health care, and is really passionate both in the areas of the heart and in the areas of the mind. So I'm really looking forward to this talk, Molly. Thanks for coming.
Thank you so much for that very kind introduction, Dr. Bell, and thank you to all of you for joining this morning. I'd like to start by giving you a little more context about me, because as you will learn throughout this talk, I'm all about context. As Dr. Bell had said, I'm a member of the Confederated Tribes of Warm Springs in Oregon, that's located in Central Oregon. We're Plateau people, culturally related to the Yakima, the Nez Perce, and the Umatilla. And I've wanted to be a doctor since I was at least 4 years old. Maybe before that, I don't really remember. I'd always envisioned myself being a family medicine physician like the doctors at the Indian Health Service clinic that I attended as a child. But it wasn't until April of 1996 when my parents and then 3-year-old sister were in a car crash, and my sister sustained a C1 complete spinal cord injury. So she's paralyzed from the neck down, has a tracheostomy, ventilator, drives her wheelchair with a sip and puff straw. She completed inpatient rehabilitation for 2 months before coming back to our home on the reservation. But very quickly, my parents realized that they were not going to be able to maintain the level of nursing care in particular that my sister needed staying on the reservation. So we moved to the town just off the reservation, Madras. And a lot of other things kind of changed with our participation in the community and kind of daily life, but a lot of things didn't change either, which I could talk about that at another time. Because of my sister's medical complexity, I was exposed to many fields of medicine because the accident happened right after I'd turned 15. So most of my driver's ed hours were actually driving my mom and sister to a bunch of medical appointments. And rather than sitting in the waiting room, I would go in with all of these different specialists and kind of see from the patient side of things what treatments were being offered and how it worked. And it was really then that I learned that rehabilitation medicine was the field that fit best with me. And I also recognized that while many other medical specialties were involved in saving my sister's life, it truly was her rehab doctors and her rehab team which helped my family learn to live again and continue to do things that we enjoy and participate, and really saved our quality of life. I have no disclosures or conflicts of interest to report other than I really love my job and I love rehab medicine. And just so you know, my sister's now 27. It's been 24 years since her injury. She's been doing really, really well, and I'm so proud of her. Want to acknowledge that I'm speaking as a uninvited guest on the Duwamish territory, Coast Salish territory. This picture is from Native Land Canada. You can, if you go to that website, you can zoom in and hover over any of the spaces, and it'll tell you which tribe, which nation was the traditional owner of the land that you're on, or the traditional inhabitant of the land that you're on. It's a great resource. And it's an important resource because it helps you see the diversity and the heterogeneity of Indigenous people across North America. And I think that's important to recognize, and it's important for me to recognize that I don't speak for all of that diversity, for all Indigenous people, for all Indigenous nations. This is kind of my perspective, and from what I've learned speaking with participants and informants from around the country, but still can't speak for everyone. In the United States alone, there are over 574 federally recognized nations, so tribes, nations, bands, pueblos, native villages, and even more who are not recognized, such as the Duwamish, and this is their unceded territory. So what we'll be doing this morning is going over some conceptual models that I use in my work, talking about specifically disability and rehabilitation for Native people, some epistemic injustice concepts, learning about sharing some of the work that I've done on stakeholder perspectives on culturally centered rehabilitation, and then some of my recommendations that I have for you based on my work. So I think the medicine wheel is a holistic health model that's not pan-tribal. It's not used for many tribes. It's really from the Plains tribes that the medicine wheel is traditional for. What I like about the medicine wheel is it's like I said, a holistic model, and I think it's very easily applied to a lot of health conditions. The traditional medicine wheel has, for the health aspects of it, you have your physical health, your mental and cognitive health, your emotional health, and your spiritual health. There's been an adaptation to this, or an update by Dr. Bigfoot, who's a psychologist who works on culturally adapted interventions for trauma in Native children. And in her adaptation, she centered spirit and spiritual health. And then the quadrant that spirit had been in is replaced by relational and social health, which is a super important concept to me as a rehabilitation medicine physician, as you'll soon see. And this individual holistic health is seated within the family, the family's overall health, the community, and the environment. And so everything is very intertwined and interconnected. The other conceptual model that's very important to my work is the biopsychosocial model of disability that was developed by the World Health Organization, the International Classification of Functioning Disability and Health. And in this model, it can be applied to any health condition, any disorder or disease, such as traumatic brain injury. And that injury, that health condition changes your body function and structure. It can cause weakness. It can cause cognitive changes with your memory or your attention. It can cause spasticity. It can cause, lead to contracture. And those changes in body function and structure impact the activities that you're able to do, your ability to walk, your ability to talk, your ability to swallow, your ability to get yourself dressed. And those changes at the activity level then impact what you're able to do at the participation level, which is defined by the World Health Organization simply as involvement in life activities. And so it can be very broad and be whatever it is that you want it to be. And all of these things are affected by the contextual factors in which that individual and family is experiencing this health condition and this disabling condition, both personal factors and then environmental factors. The environmental factors are things such as the built environment, whether there's paved roads and curb cuts that would help you to get around in a wheelchair if you were a wheelchair user. It's rural versus urban. It's climate, because there are some conditions that are very climate sensitive, such as my sister's spinal cord injury. She's poikilothermic, so she can't regulate her temperature as well. So if it's too cold out, she can't go outside because she would get hypothermic. And then also parts of the environmental factors are the attitudes that people have. And so whether you come from a community and a culture that is open and welcoming to people with disabilities, or whether you come from a community or culture where disability is more shameful, whether you come from an ableist perspective, and I will say that medicine in general is very ableist, and we should all be aware of that. And then the environmental factors also include the institutions, the laws, and the policies that govern civil life. And so, like in the United States, we have the Americans with Disabilities Act, which just turned 30 years old. In other countries, they might not have other similar protections that help ensure access. Or, and when I say ensure, we still have not yet achieved the full impact of the ADA, but there are other countries that are worse off. And so this is a really important model that underpins rehabilitation practice. And I really think that the medicine wheel and the ICF model are very complementary to each other. Okay, so moving on to talking about some more specifics about disability and rehab for Native populations. So Native people have a higher prevalence of disability than the total general population, and that inequity grows across the lifespan. So it's only a fairly small inequity for children, but then by the time you get to the elders, it's a much higher prevalence of elders have disability than the general population. Very little is known on the prevalence of disability in Native children, really. Data from the Survey of Children with Special Healthcare Needs found that Native children are more likely than non-Hispanic white children to meet criteria for special healthcare needs based on functional impairments or disability. And they're more likely to have 3 or more functional difficulties, so more functional impairment, more disability. And Native children with special healthcare needs are less likely to receive care in a medical home. So I've published research showing that Native children have worse outcomes during inpatient rehabilitation than non-Latinx white children. And that's really kind of what set me on my research path. Research with Native people without disabilities found that cultural activities and cultural connection are key for health and wellness for people in tribal communities. And several studies with Native people without disability have found that interventions that incorporate culture and cultural activities lead to improved health outcomes for Native people. And both in my family's experience, such as when we had to move away from our reservation, couldn't participate in cultural activities in the same way, disability can be an assimilating force. Disability and medical complexity can be an assimilating force that moves Indigenous children and families kind of toward the Western medical culture, rehabilitation culture, sometimes actually moving them away from their communities to different communities so they can get care. And this happens in other places too, with other Indigenous people. There is a study with Aboriginal elders in Australia who, after stroke, which is usually associated with a pretty high level of need for rehabilitation services, many elders would refuse those services because it would necessitate them moving away from their community. And being in their local community was such a kind of a fundamentally important benchmark that as long as they were able to be in their community, it really limited their perception of disability. And so they didn't feel like they needed to use the services if they could stay in community. So, but for a lot of children and families, there's been this push towards the medical culture, towards kind of rehab. And so that leads me to ask, how can the rehab system better support and facilitate the child and family's cultural participation, kind of helping actively push them back and enabling their participation in their Indigenous culture? And that's one of my career goals, to improve health, function, and participation for Native children and youth with disabilities by creating a culturally centered rehabilitation care model. So one of the first steps in doing this was to better understand disability and rehabilitation amongst Native children. I conducted a qualitative research study with Native kids with disabilities and their parents using questions that were framed around the ICF model. And similar to research with other Native populations, the participants in this study shared how cultural activities were an essential part of health for people from their tribal community. And one participant said that health and culture are all under one umbrella. However, many families also shared how their child's functional impairments and disability really limited both the child's participation in cultural activities, but the whole family's. One mother said, "Kids dig the clams to learn the traditional ways, but she wasn't able to go to the beach in her wheelchair." Now, there are wheelchairs that are designed specifically for beach access. They're not covered by insurance, but there are several grant programs where they're fairly easy to get. But the need for a beach chair was never addressed in any of her child's rehabilitation encounters. Just like with a beach wheelchair, the barriers to participation for most of the participants had potential rehabilitation solutions. But for the most part, rehabilitation services did not address the child or family's participation in cultural activities. They didn't uncover the functional goals related to culture or cultural activities, or work to minimize the barriers to participation. So rehab providers, rehab doctors and therapists, a group that has expertise in function, enhancing participation, approaching kind of barriers with a problem-solving lens, didn't know about these functional needs related to culture. And the parents didn't feel empowered to bring them up. They didn't feel like it would be the business of rehab, that would be something that would be able to be addressed in the rehab space. So thus, rehab services are missing this key opportunity to help Native children and youth participate in cultural activities and therefore improve their health and overall function. It did lead me to ask, though, too, like, who decides what happens during rehab? And theoretically, and what we aim for and what we strive for is for the goal setting process to be patient and family centered. With studies that were done, they did find that goals that were developed during rehabilitation were strongly influenced by the clinician views.
Well, thank you.
And
Reminder to mute, everybody.
Please mute.
Thanks. Happens every time. Thanks, everybody.
And then another study found that patients' perceptions and kind of thoughts around the goal setting process during rehabilitation was quite different from that of clinicians and professionals. And so this is, I don't think that this is it's not based off of malice or kind of intention to exclude patients and families from the goal setting process, but I do think that there could be some concepts related to epistemology, kind of, which is the study of knowledge and how knowledge is gathered, and how power differentials play into medicine and healthcare in general, and also in rehabilitation. And so there's this concept of epistemic injustice, which was defined by Miranda Fricker, who first published on this, as a wrong done to someone in their capacity as a knower. And there are two different types of epistemic injustices: testimonial injustice and hermeneutical injustice. Testimonial injustice is a person who's hearing the patient kind of doesn't give them full credibility, maybe doesn't fully believe what they're saying. There's participatory prejudice, so who actually gets to be part of the knowledge building and the knowledge gathering activity, kind of whose knowledge matters. There's informational prejudice, where you'd think that that the person doesn't have that the information that's being given isn't relevant to the problem at hand or to the knowledge building activity at hand. And it can be internalized, where people are afraid that they're going to be receiving testimonial injustice or receiving informational prejudice, and so they're just choosing not to share their knowledge, not to share their story. This is countered by epistemic privilege. And so health professionals have earned epistemic privilege. We have years of training, we have specialized knowledge, and our knowledge is usually pretty well respected. Past few years, maybe not so much within society, but in general, health professionals are well respected with our knowledge and our opinions. But we need to be very wary of unwarranted privilege, where the knowledge that we have and the interpretation oversteps into somebody else's decision-making domain, such as in decisions about quality of life. And so I encourage you to always ask yourself how you can balance that epistemic relationship. The second type of epistemic injustice or hermeneutical injustice really refers to those gaps in collective interpretive resources and not recognizing what we don't know. And there's an important concept that I was just exposed to through some learning that happened on Twitter with from Dr. Twyla Baker, who's a Mandan Hidatsa PhD level educator, who develops this concept of translational exhaustion, where Indigenous people or other marginalized groups that engage with the larger population on a subject related to bias first have to set the stage and set in the terms of historical context all the way to the current day state of affairs before even addressing that said topic of bias, due to the lack of education and background that the listener has. And that's directly related to the erasure of true Indigenous history, kind of beyond the small amount we receive in our school systems. I will say, as a parent of a child in public education, it is still very, we still have a far ways to go on the education about Indigenous history in this country. So our families, our Indigenous families, I suspect or feel that translational exhaustion. They might not verbalize it as such, but that kind of bone deep exhaustion and like having to choose whether or not to enter into that space to try to make themselves understood. And sometimes they might decide that that's just too much effort, especially if they feel like the information is not going to be valued or respected. There's also cultural differences in the interpretation of information and experiences. And recognizing and responding to the experience of others requires the ability at some level to understand those experiences. I know you've all seen this picture before. There's many problems with this visualization, which I won't get into here, because the main reason I'm including it is I want to contrast it with this modification, which was created by Abigail Echohawk of the Urban Indian Health Institute here in Seattle. And what this picture is showing to me is, what if we don't want to play your game or watch the game? Native people, Indigenous people, and communities have self-determination to determine what their goals are in all things, including health. And so it's important to find out what that is for each person. Might not be the sports. One of the participants in my first qualitative study talked about how it's all about adaptive sports. Why is it all sports for children with disabilities? And I was like, you're right. There are lots of other things that are out there. And then there's another new model that I've been seeing over the past few months with tree. This tree kind of bends up so it's more equal. My question with that is, what if we eat the apples? What if we eat the salmon and the piaki and the lucamine? And so kind of just always reminding yourself that what is like normal for you is not the norm for everyone. So don't ignore the person's interpretation of their experience by not eliciting or excluding their lived experiences from the decision making and the information building process. Now I want to share with you some of the work that I've been doing on stakeholder perspectives on culturally centered rehabilitation. And this is kind of grounded in another model or another approach called two-eyed seeing, which was developed by a group of Mi'kmaq elders. So they're from the Eastern Canada in the Atlantic, and they're academic partners. And this concept of two-eyed seeing is where you see from one eye with the strengths of Indigenous knowledge and ways of knowing, and from the other eye with the strengths of Western knowledges and ways of knowing, and then using both of those eyes together for the benefit of all. I think both systems have a lot to offer, and you can't ignore one without doing an injustice to the patients that we serve. And so what I've been doing is stakeholder interviews with patients who've undergone rehabilitation services, parents of Native youth who've undergone rehabilitation, providers of rehabilitation, outpatient rehabilitation services, both Native therapists and non-Native providers, and then with Native community leaders who are either involved in healthcare decision making or kind of child and family services within their community. And the questions have been about what the necessary components of culturally centered rehabilitation would be, the barriers and the facilitators in the current rehabilitation environment. And some of the necessary components that have come up have included incorporating traditional cultural activities into the rehabilitation activity, empowering parents and patients to direct their care, and then having specific tools to help providers and families communicate about culture and their functional goals related to culture. Notable facilitators of culturally centered care included earning and maintaining mutual trust, having support from the community and from elders for children with disabilities and their families, the ability of rehabilitation services to be flexible in their delivery, and then having more American Indian and Alaska Native rehabilitation professionals, which you think about how underrepresented Native physicians are within healthcare, and Native rehabilitation professionals are even more underrepresented within the rehab therapies. And then the barriers that were brought up, access, so both geographic access, and then even for people who are more kind of centrally located or not rural, it's not just geography that impacts the access to services. The lack of provider knowledge about Native cultures, and those two things were mentioned by almost every participant in the study. Providers being unsure, asking questions about culture and being unsure about what to do with the answers to those questions. And then from the provider perspective, that the time it takes to build strong relationships and to develop that therapeutic alliance doesn't count as billable treatment time. And so there's that, that time pressure that people experience as well. So looking at the barriers to care, kind of more about the trust and discrimination, this was a study that was done with people covered by public insurance programs in Minnesota. And when they looked at the American Indian participants in that study compared to the non-Latinx white users of public insurance in Minnesota, the Native people were more likely to say that doctors don't understand their culture or their religion. They were more likely to endorse low trust in their providers. The adults were 4 times more likely to report discrimination. Parents, so Native parents, were 24 times more likely to report discrimination than the white parents. And there have been many studies that have talked about the impact of discrimination and racism on healthcare and the decision to utilize healthcare. So there's quite a ways to go on this aspect as well. And then calling back to that idea of translational exhaustion and kind of whether an individual patient who's already on the low end of that epistemic balance, based on societal privileging of medical knowledge and the known provider's lack of knowledge of culture, want to talk a bit about historical trauma, which is one of the key things I think needs to be understood about Native communities when we're entering the healthcare space. And there's a talk I have on historical trauma that lasts a whole hour, so you guys are going to get like the little snippet version of it. Historical trauma is also known as intergenerational trauma, collective trauma, and I like to use the definition that includes the 4 C's. So the first C is colonial, so it's results from a colonial injury where there was a conquest, subjugation, or dispossession of the indigenous group by the colonial power, the settler colonialists. It was a collective experience of a community that led to a change in their identity, their ideals, their interactions as a response, such as being moved from your traditional lands 1,000 miles west into a new territory. It's a cumulative effect through historical sequences of adverse policies and practices by the dominant society. This is the systemic racism part, institutional practices that prevent you from kind of living your same cultural ideals. I think one example that comes to mind for this is when reservations were created. To leave the reservation, you had to get a pass from the Bureau of Indian Affairs agent on your reservation. If you didn't have the pass, you were off the reservation, kind of illegally, and you could be punished for that. And so for people who, like on my reservation, our roots that we gather are in our reservation boundaries, but pretty much our other traditional foods were not within the boundaries of our reservation. And so you'd have to seek permission to leave, to pick huckleberries, to fish at Celilo Falls, to hunt deer, to trade. And if you were denied permission, you had to either go without or risk being caught. And that's why the phrase off the reservation is not a good one to use. And then it's a cross-generational impact. So this is that legacy of risk and vulnerability. Other historical trauma scholars have really looked at the role of the broader societal response, the dominant society response to the historical trauma, and recognized that response perpetuates historical trauma amongst Indigenous communities, and specifically the ignorance, indifference, or avoidance of Indigenous history. And found this on Twitter from an Indigenous person, that something I don't think occurs to settlers is that Indigenous people already are living in a post-apocalyptic world. In 1491, it was estimated that there were over 5 million Native people living in North America, or living in what's now the United States of America. And in 1900, there were estimated to be 250,000. So a massive loss of population. I went to a conference in Hawaii a few years ago it was an international conference for Indigenous physicians. And one of the workshops that I went to was led by a Kanaka Native Hawaiian artist who was approaching historical trauma healing from an art perspective. And there were about 20 of us in the conference, and I can't remember how they randomized us, but 2 people survived in that, and 18 people were supposed to be approaching the questions that they were asking from the perspective that they didn't survive the invasion and the contact with settlers. And then we went through this art experience, and it was such a powerful thought that 10% of your population survived. And that when I saw this quote about already living in a post-apocalyptic world, it really spoke to me. And I think that really highlights the resilience of Native people and Indigenous people. And I encourage you to always think about that resilience aspect rather than the deficit aspect. And then for approaching your own ignorance, since I'm not expecting, it's not your fault that the American education system woefully ignores true history. This is a new resource that was from the Natives in Philanthropy group, History Through a Native Lens, and it was written by Dr. Karina Walters, who's the director of the Indigenous Wellness and Research Institute at the university, housed at the University of Washington in the School of Social Work. I encourage all of you to go to this website. It's really well laid out, and you can kind of go through time periods and see both what was happening kind of from a settler colonialist time frame, but then also some of the Indigenous accomplishments in the same time frame. And so it's just a really well done timeline and a well done website. You can also download the PDF if you want it offline. Then I think that from a historical standpoint, and particularly from a pediatric standpoint, one of the most important things to recognize in Native history is the impact of boarding schools. So boarding schools were created as a tool of assimilation. So after kind of the initial period of conquest and settler colonialism happened kind of throughout the West, the focus went from conquest to assimilating Native people into dominant society. And boarding schools were a key tool of this, where all traditional practices were punishable. And Richard Pratt, who was the leader of the Carlisle Indian School, his motto, which I think is more well known, was, kill the Indian and save the man. And anything, the way you dressed, your hairstyle, your language, your religious practice, traditional medicine was prohibited in the boarding schools. Around the same time, also, a law was passed that made it illegal for Native people to practice their religion in the United States, which is ironic, given that freedom of religion is supposed to be one of the founding principles of the country. But Native people, for about 100 years, were prohibited from practicing their religion. And since so much is holistic, that meant oftentimes prohibited from practicing their traditional medicine. And this removal of children from their families, because it was a forced removal or a coerced removal, remains a source of historical grief, altered parenting, altered family structures. It deprived generations of children of their parenting. It disrupted the transmission of healthy parenting practices, transmission of cultural knowledge, and instilled new negative behaviors. Boarding schools have this horrific legacy of physical, emotional, and sexual abuse. And the community lost human capacity. They lost future leaders to boarding school and to the traumas from that. I think it's important to recognize, too, that kind of forced removal of Native children from their families and the role of the Indian Child Welfare Act, which is supposed to now keep Native children with their families, or at least with their communities, and how often we're still kind of failing with that, particularly with Native children with medical complexity and disability. So in my first qualitative study, when I was doing my screening and for recruitment, one of the exclusion criteria was if the child was in foster care or adopted by non-Native people, they were excluded. And over half of the kids who had been seen in the rehab clinic or the rehab therapy clinic actually had to be excluded because they weren't in community care. And so I think there's a lot of opportunity for building community capacity for helping care for Native children with disabilities and medical complexities to try to keep them within their culture. So the causes of historical trauma in Native communities, the mass death, that's the part that you learn about in history class. The loss of land, the destruction and desecration of land. So this is the six grandfathers in what's now South Dakota and Lakota territory, which now has Mount Rushmore carved on it. This is a local example. This is Celilo Falls, which was the economic center of life for the Plateau people, for my people. My great-grandfather used to fish here, and in 1957, it was flooded by the building of the Dalles Dam. Forced and coerced assimilation, such as through boarding schools, and then forced and coerced sterilization, and many other things as well. And this quote is from Les Whitbeck, who's one of the premier scholars of historical trauma and Native people. And I think it's an important quote. It's, the historical losses are not historical in the sense of happening long ago and a new life has begun and it's in the past. They're historical in that they originated long ago and have persisted. And the reminders of historical loss remain ever present, represented by economical disadvantage on rural reservations, I would say in urban communities as well, national disrespect, discrimination, and a sense of continual erosion of traditional cultures. And while there have been some kind of fairly high-profile wins recently in the media, both with the Supreme Court decision in the McGirt case, a Supreme Court decision in the Herrera case a few years ago, which renewed tribal sovereignty. It's hard to call it a win because it's just affirming what was in the treaty, and the Constitution says that the treaties are the law of the land. And so if we're considering a win, kind of this bare minimum thing, like the Washington football team changing their mascot after decades of activism against using a racial slur, and those are wins, like how low is our bar? Speaking of bars and low bars, this is an example of how policy and law impacts Native people and Native health. So the Indian Health Service operates under a funding cap, which was codified in the Snyder Act of 1921, which says that that Native health gets yearly appropriations for their health care. And this is in contrast to entitlement programs such as Medicare, which what is spent is what is spent. And so per capita healthcare expenditure for the Indian Health Service is significantly lower than any other kind of health program in the United States, leading to, and this severe underfunding leads to problems with access. It leads to problems with quality in Indian Health Service care. And because the Indian Health Service funds also go to tribal communities, it's really such a small pot of money that that communities have to work with to try to improve their health. So that's a big problem. And there's also ongoing contemporary traumas where, there's attacks on, or threatened attacks on sovereignty, on sacred land, on the environment. I think the risk of Native people with environmental injustice could be its own hour-long talk. But there's a lot of worry and a lot of emotional energy that Indigenous people have to put into fighting these travesties that takes away from other things they could be doing to build the community and build their family and their own individual health. Not to mention that, water protectors and defenders of sovereignty are arrested and imprisoned for standing up for treaty rights. Other contemporary traumas include police brutality against Native people. And, not that it's a competition, but Natives were killed by law enforcement at a higher rate than any other racial or ethnic group based on population. And this picture is a picture of John T. Williams's carving knife and the totem pole he was working on. He's the carver who was killed by the Seattle police about 10 years ago. And that's the knife his knife was closed, and the officer shot him feeling threatened by the closed knife. Another contemporary trauma is murdered and missing Indigenous women, which first, I think the Canadian First Nations women were the first to really raise this issue, and it's really has gained more national knowledge across the United States, but kind of the role of the Violence Against Women Act and that being allowed to expire and its effect on Indigenous women is a major issue. So, historical traumas mixed with contemporary traumas. And you might be asking yourself, what does this have to do with rehab or with healthcare? And I just want to, everything can impact rehab and healthcare and how you experience your health. This is part of the environmental factors that Native children are living their life, that Native families are living their life in, and it's going to affect how they participate with institutions of the dominant society. So what I'm working toward now is working with a community, or want to get funding first, but then working with a community-based stakeholder group to really develop a culturally centered rehabilitation model of care. And then based on the preliminary work that's been done, the components that will be part of this model or that will need to be addressed include kind of structures. How do we get more Native people into the rehab professions? How can we better improve access to rehab services? How can we be flexible in our service delivery? How do we help people, help both providers and patients be ready to talk about their culture? And really, it's the providers that need to ask to cede that epistemic space, that knowledge building space, and invite people in to share their knowledge. That the providers need to truly be aware of historical trauma and the social determinants of health so they're not perpetuating the traumas. Helping parents be empowered to really fully engage in their child's rehabilitation care by learning about their condition, kind of involving elders and other people who have raised children, Native children with disabilities, acknowledging the competing needs that families have will be really important. And that's one privilege I want to acknowledge for myself and for my family. Since my sister was injured in a car crash and her booster seat had malfunctioned, she had a settlement that paid for a lot of the things that health insurance doesn't pay for. Also, my mom was a teacher, and so before the lifetime limits, when lifetime limits still existed with the Affordable Care Act, when my sister had met her lifetime limit, the Oregon Education Association renegotiated with a different insurance company so that my sister, the end effect was that my sister continued to have health insurance and coverage for her needs. And so those are two major privileges that my sister and family had that not all people have. And then finally, the incorporating cultural activities into rehabilitation. So the spiritual aspects of care are something that several patients and Native rehab providers had brought up, and kind of the sacredness of the rehab space when people are working so hard towards their goals and trying to get better, and there's that hope, and how you acknowledge that sacred aspect of it. Involving elders with the cultural activities and so on and so forth. And so in addition to these components, I also think that culturally centered care will need to incorporate the tenets of trauma-informed care. And these include patient empowerment, choice, collaboration, trustworthiness, and safety. And so asking yourself, like, what can you do now? I think the first thing is educate yourself. Go to the Native philanthropy sites and look at the Native, history through a Native lens that Dr. Walters had put together. When COVID precautions end and you're able to, attend community events and cultural events, so that when you ask a Native patient what sorts of things they like doing, and they tell you something, you know what that something is. Ask questions. With Native I'm familiar with what their cultural activities be for their tribes, I will ask kind of specific questions about those cultural activities if they're participating. But my go-to question for all of my patients, kind of regardless of their ethnicity or their cultural heritage, is to ask what sort of things are important for your family to do together, either in your community or at home. And I've gotten so many fun answers for this and really gotten a chance kind of from that rehab perspective to help families problem solve around their participation and improve their child's true participation in these activities that are meaningful for their family. When you're hearing the answers to questions, though, it's also really important to be non-judgmental and try to maintain a pleasantly neutral countenance that people still feel comfortable sharing with you. If you ask a question and they answer it and you're like, ooh, you ride ATVs, or you do something that's, makes you feel uncomfortable as a provider, that's going to shut down that flow of communication and that sharing of knowledge from your patients. So pleasantly neutral. Acknowledge the competing needs. Like, we ask our families to do so much for their children, and they have other things that they need to do, and everybody is trying their best. And so acknowledging that and validating that is so important. Cede your epistemic power when you can. Acknowledge when you are not the expert and you need to bring those other experts in, the patient and the family, and help them see that they are the true experts in what their child needs. And really assess the environment that you create. That's something that we do have a lot of control over. And it's part of that safety aspect of trauma-informed care. And so that includes the physical environment. So the lighting and the security presence, the amount of noise that's in your environment, whether or not your signs are welcoming, and the art that you have. And so I think, here at Seattle Children's, we have this great example of the beautiful piece by the late Marvin Oliver. But a few years ago, we didn't have great welcoming art down by the river Starbucks, when there was that picture of Alaska Native children in the boarding school era who'd very clearly been kind of shorn of their cultural appearance. So I'm very happy that picture is gone. And then the social environment that we create. So all staff and the interactions that our patients and families have with all staff, and that we're consistent in our approach, that we're communicating openly and transparently, and always with respect. And so just want to say thank you to the Center for Diversity and Health Equity and their Health Equity mentored scholars who's been supporting my work, to Dr. Coker, Dr. Rivara, Dr. Bjornson, who've been my mentors, to Dr. Amy Unwin, a rehabilitation resident who's helped me with the qualitative project, and with Catherine Lent, soon to be Dr. Lent, who also helped me with the research projects. And I'm happy to take your questions now.
Thank you so much. This was really, really interesting and important talk. And we do have a comment from Shaquita Bell. And Shaquita, if you want, you can unmute yourself on purpose for this, but I'll read it. Thank you, Molly, for this phenomenal talk. Can you describe any recent examples you have of patients or families maximizing this model of bringing Western and traditional healing together? For instance, I had a recent patient at Harborview that we connected with equine therapy, and they rewarded us with the first smile in weeks.
So I think one of my recent stories comes from my outreach clinic in Alaska, and at the Alaska Native Medical Center, talking with a teen with cerebral palsy about their participation in cultural activities. And she mentioned how when she was younger, she was still able to get into their community hall because she could be carried up the stairs. But since she, got heavier and nobody was able to lift her in her wheelchair anymore, she had to just stay home and not go to her cultural ceremonies and her cultural gatherings and shared community space. And so a good portion of our visit was spent talking about that community space and who in the community could enable access, because it turns out that their village administrative offices are in the other half of the building. And there was a ramp to that half, but there was a locked door in between. And so we talked about kind of access issues and how to how to approach that access issue from an advocacy perspective. And with the mother, with the mother and the child, we identified who in their village should be approached to open that door for the child so that she could get into the space for community cultural activities. So I think that's one example. Also at the Alaska Native Medical Center, because they actually have two Alaska Native occupational therapists who have started doing sealskin sewing with their older patients and with their elders, and kind of bringing that cultural activity in. And I think that's going to improve their fine motor skills much better than anything else that could be done.
Thank you. And lots of comments in the chat. Thank you so much for this wonderful and eye-opening talk. And then from John Cogan, this is a great talk. Thank you, Molly. Is there anything we can learn from our Canadian neighbors about how Natives interact with healthcare there?
Yeah, so I think that Canada, many countries are ahead of us with respect to kind of Indigenous interaction with healthcare. I think that Canada had their Truth and Reconciliation Commission a handful of years ago, and one of the results of that was some specific kind of point-by-point things that Indigenous could be done to improve Indigenous access to healthcare. That said, from the rehab perspective, there's actually one of the physical therapist and a rehab group in Canada wrote about how those truth and reconciliation points need to be adapted into rehab, but there is no steps, nothing, just like, we should do this. And so there haven't been kind of an operationalized model yet. And from conversations that I've had at conferences with an occupational therapist who served a First Nation community in British Columbia for quite a while, there's still a ways to go with that intersectionality between Indigenous and health and disability. And so I don't think we're quite there yet. Similarly, when I've spoken with some Maori providers, like at this conference that I had gone to, they have not yet really incorporated people with disability into some of their work, which is one of the things that one of the reasons why I wanted to do this work is so much of the health interventions for Native communities do involve kind of that cultural revitalization piece. But if people with disabilities and children with disabilities aren't able to participate in that cultural activity, they're missing out on that health benefit. And so I think from a rehab perspective, there's a lot we can do to help enable that participation. But also from a community perspective, the community leaders and the people who are organizing those cultural revitalization events need to make sure that they're inclusive and accessible, and things are being done to truly welcome people with disability into that space.
Agreed. Thank you so much. We're almost out of time, everybody, but I just wanted to echo some of the comments in the chat from Dr. Sugarman, Dr. Pasloff, from Sahar and Erica Metzenberg. We are so appreciative of your incredible research and this powerful presentation, and we all learned so much. So thank you so much for being here, Dr. Fuentes, and for everyone who has attended online. We really appreciate you, and I'm sure you can contact Dr. Fuentes if you have any more research funding for her or more questions. So thank you so much, everybody, and we will see you all next week. We really appreciate you.
Thank you, everyone.
Thank you. That was great.